Okay, so everyone was able to watch the video during Irma, right? Hopefully. Oh, so you'll watch it eventually. Hopefully, at some point you did. So, any questions from that section? And the derm stuff should be pretty straightforward for a lot of that. Okay, so we're gonna talk about ophthalmology. So, it's important to talk a little bit about application of medicines to the eye and kind of different things about absorption, how we can apply these medications in different ways. And so you can even see here in this picture, always kind of freaks me out a little bit. I don't know if any of you guys have weird eye things. I don't like the idea of needles going in or around eyes, but it happens. So you can see here, there's many different ways you can apply medications. Obviously, what's kind of the most common way to do it? Yeah, so topical administration. So when I say topical in the sense of eye medications, I'm just meaning applying like drops or gels or things like that directly to the eye. That's usually the most common. It's the easiest thing we can do. But there are other ways to get medications in or around the eye. So you have things like subconjunctival injections, which you can see right here. You have retrobulbar or peribulbar. So different ways, and depending on where the site of infection is or whatever type of disease you're treating, you may need to apply the drug in different places. And this is how we can do that. So just be aware that with these different routes, you're going to find different characteristics as far as the way that absorption occurs and other kind of limitations and whatnot. Again, topical is the one we're going to focus on most here, mainly because it's the most common way we're going to give these medications. The nice thing about the absorption is that typically you don't have a ton of absorption of medications when given to the eye. You have a little bit, but there's there's enzymes in the eye that can degrade certain drugs. One of the big things you have to worry about is that once if you have a liquid in your eye, and where does it eventually drain out to? Yeah, through the lacrimal duct, right? That's actually a very highly vascular membranous area where you can actually have absorption of drug. And so that's one of the things we're going to talk about is how some of these drugs can have systemic effects, even though we're applying them in the eye, because of that absorption through the lacrimal duct. And that'll also be important when we're talking about how to actually apply them, and we'll talk about some techniques to limit that. But the utility here is that they're going to be very convenient. It's pretty economical. One thing you always want to make sure that patients are doing is complying with it appropriately, so make sure they're educated on how to apply the medications right. You can certainly see that in some cases, patients can actually, if they're not cleaning the substance correctly, or if they're potentially if they have an infection, they're touching, like say, the dropper to the infected area, they can actually spread disease potentially or reinfect themselves. So there's some things we'll talk about to go along with that. But this is going to be the main one we're going to focus on here. Just note that these other routes are available. They all have kind of their drawbacks, but these are going to be more for like kind of specialty sort of procedures, or if you're working like with ophthalmology directly, you're going to do these more frequently. So. There's other ways we can also do certain dosage forms, like we can do inserts, we can do like implants basically, and so this is kind of an interesting one where you can actually implant this back into the bulb of the eye. You can actually have nice sustained release of drug there, and so it can stay there for a period of time. This is one they would do for patients who have cytomegalovirus retinitis associated with HIV, pretty progressive HIV, so you may see that done very occasionally. We also have other things like we have gels, we have ointments that can be applied, and obviously the thing you have to realize with the dosage form is how long do you think a liquid stays around versus say like a gel? Yeah, liquid washes out a lot more quickly, right? So that's going to be important when we're talking about how to apply the medication to make sure we get kind of the full effect of it, because otherwise it's going to wash out either down the face or it's going to go into the lacrimal duct, and it won't, if it's not there at the eye, it's not going to be working quite so long. Whereas things like ointments, gels, they tend to stick around for a lot longer, and so they can have better absorption there. You can also have sometimes you have solid inserts that can be applied as well, but these are more kind of specialty items that we'll deal with less occasionally. But basically, the thing to note here is that the more time a drug has in the cul-de-sac, and what is the cul-de-sac besides what you live at the end of, maybe? Yeah, basically, yeah, that kind of that space between the eye and the subconjunctiva, right there is that cul-de-sac. So the longer the drug's staying there, the better the absorption you're going to have. So again, as far as absorption goes, you're going to find that the time in the cul-de-sac and also in that kind of precorneal tear film, the longer it stays there, the better absorption you're going to get. Again, we can have some systemic effects due to nasolacrimal drainage, which we'll see. And then also you can have some absorption happen due to drug juice binding to like tissue proteins and things like that. Not super clinically important here, but certainly this nasolacrimal drainage we'll talk about more in a few seconds. Some drugs will diffuse across the cornea in the conjunctiva, and that's where it can actually have its site of action. So if you have an infection or something like that, you can actually have some absorption occurring there. And this can be affected pretty significantly by either changing the drug formulation, whether we're giving it as a liquid or a gel or ointment or something like that. And then also in some cases you may actually find that we can block the tear ducts. You can either put like silicone plugs into the nasolacrimal duct, or you can actually cauterize it to close it off. They'll do that sometimes with patients like chronic dry eye in order to make sure that stuff kind of sticks around for longer. So maybe something you see done occasionally. So looking at where tears are going to be kind of developed and where they're going to be going to, and this is a similar pathway that the drugs will take, because they're going to get carried away with the tears. Again, as they go wash through the cornea, through the aqueous humor, eventually go through the iris, it'll end up going through systemic circulation. See kind of the same thing happening here along this pathway. And so you can see the the lacrimal duct here where those drugs can go down, eventually empty out into the nose, and again, absorption can happen pretty significantly. The other thing to note is that sometimes you can have some lag time where the drugs take a little bit to get absorbed to cross that barrier before they'll really have effect. So these are not going to be as immediate as you would see with an actual injection, but they'll still be pretty quick for the most part. The other nice thing is that when you're giving drugs via the ocular route, you guys remember that first pass metabolism? What is first pass metabolism? Yeah, it's orally administered medication go through the liver first, and then they get absorbed. This bypasses that, so that can be another thing where you can see better absorption of it. It doesn't get hit by the liver, so that can be a nice thing there. But it could also lead to more systemic side effects, which we'll see with some of our drugs. We'll talk about a little bit later. You guys remember that fixed law we talked about in from the basics class? This is the same principle you're going to see here affecting drug absorption as well, right? So again, the bigger the concentration gradient, the larger the area, and again, how thick or thin do you think the actual permeating across the eye is going to be? Pretty thin, yeah. So again, drugs have a pretty easy time getting across here, as long as they're lipophilic, as long as they have a decent concentration gradient, they have a pretty decent flux through this. As far as distribution goes, once it gets into the eye, you're going to find that it occurs pretty similarly once it gets into systemic absorption. Nothing really changes there, but you can actually find that some drugs will accumulate in the eye. So this is actually an interesting one called chloroquine. It can actually accumulate in the retina and cause a bullseye lesion that you can see there. So it's kind of a unique finding, unique side effect of chloroquine. It's kind of an old school anti-malarial drug that we don't really use all that too often anymore, but just to kind of illustrate the point there. So some drugs also get metabolized in the eye. This is less common, but certain things like this dipivefrin actually gets converted into epinephrine within the eye. So that's kind of the active form. And you guys remember what we called it when you have an inactive drug product being given that has to be converted over to the active form? Prodrug, yeah. So this is kind of a similar thing here. We have latanoprost gets converted over to prostaglandin F2A, and we're going to talk about that drug later when we're talking about glaucoma meds. And then once it gets to the liver or the kidneys, it undergoes the same process as it would if you gave it IV or orally. So we'll talk a little bit about ocular antimicrobials. Again, we're going to find that infectious disease of the eye is going to be pretty common complaint for people coming in. Several different types of periocular infections you can have, either preseptal or postseptal. And we're going to see that deciding on the route of antibiotics depends on the patient's specifics. So in some cases, you want to get away with using ocular antibiotics. In some cases, you have to administer systemic antibiotics in order to treat those infections. When I say systemic, I either mean orally or IV in those cases. So again, it depends on the clinical setting. Are they coming in secondary to a trauma? Those typically are going to be more severe or more severe risk for infection. They might be more likely to use systemic antibiotics. If they're immunocompromised, meaning if they have either cancer and they're neutropenic, or they have HIV and their CD4 count's low, they may be more likely to need systemic antibiotics because they don't really have the ability to fight off the infection on their own, right? And then also just looking at how involved the disease is. As it gets more involved, more diffuse, it's going to be more difficult for just ocularly administered medications to really kick that infection. So you're going to have to give more systemic drugs. And so again, it's going to come down to how does the patient look, what are their specific factors in deciding, can I give them oral drugs or do I need to just give them ophthalmic medications? So again, we'll find that the spectrum of disease changes over time, especially with things like H-flu after the introduction of the vaccines has been going down pretty significantly. And again, typically when you're dealing with kind of small, mild, kind of peripheral infections, you can usually get away with topical antibiotics. The nice thing about giving topical antibiotics is you get very high concentrations such that you really don't have a lot of resistance developed to that. So even though you may have an infection, say due to strep pneumo or something like that, even though if you were to culture it out, it may say it's resistant to something like erythromycin, we're giving much higher concentration when you give it in the eye. So because of that, you can usually overcome a lot of resistance. And you're going to find a lot of these infections you don't even do cultures for in the first place. So the other problem, though, with giving ocular medications that you typically have to give them very frequently because, again, they get washed away, and so you need to give it more often in order to make sure you keep those levels up. Okay. So typically we use pretty broad spectrum antibiotics, meaning what does broad spectrum mean? Covers lots of different bacteria are going to be covered by these. And again, we typically don't get cultures unless we're worried about our immunocompromised patients. So especially if they can have fungal infections and things like that, you might be worried about. So looking at conjunctivitis, again, most of the causes for conjunctivitis, viral, right? So you're going to find that even though most of these cases are viral, we don't necessarily, and I always say, if you have a viral disease, should you ever get an antibiotic? You should, right? You should never do that. But this is actually one of those cases where oftentimes, because resistance isn't really an issue here, we can sometimes give antibiotic ointments in these cases. So I'll talk about that in just a second. But just note that in some cases you may find that patients have immune-mediated reactions, which obviously antibiotics aren't going to help with a whole lot there. Tumor, systemic disease can all be causing this. And then looking at the pathogens, we can see here you have some gram-negatives like Neisseria, Haemophilus influenza, Strep pneumo, Staph aureus. So again, we want antibiotics that can cover a pretty wide range of things here in order to help treat this. Obviously, our goal of treatment, eradicate the infection, try to prevent recurrence. Here are the list of ocular antibiotics we have. It's nice because we've already kind of covered these for the most part, so this will be more review, which is good before the test, right? And so we'll talk about these a little bit and any kind of special kind of ocular idiosyncrasies with them. So first off with the macrolides, you guys remember how these work? Yeah, how are the macrolides? So yeah, so protein synthesis, they're blocking that, right? So block protein synthesis. The most common one we're going to use here is erythromycin ointment. This is the most common. It's cheap, widely available. People can get it pretty easily, right? With a prescription. So this is the most common one we're going to use. You can also have things like azithromycin, but this typically is a lot more expensive, so we don't use it unless we have a compelling indication to do so. So again, using this for bacterial conjunctivitis. Obviously, as far as adverse effects go for these drugs, you're going to find that eye irritation, possible hypersensitivity is always a risk. There's nothing kind of new with this. So just kind of keep that in mind for all of these drugs. But if there's any kind of unique side effects, kind of key in on those because those are going to be the things that kind of differentiate them from one another. And the other nice thing is when you're giving these things topically, no drug interactions to really worry about, right? Because you don't have to worry about them interacting with anything systemically. So that's kind of another benefit. Because if you guys remember, what type of drug interactions could you have with a macrolide? CYP3A4, right? It's almost like it just came up on the test or something. Yeah, so CYP3A4 gets affected by the macrolides, but we don't have to worry about that when given it ophthalmically, which is the benefit. So again, note that erythromycin typically comes as a gel. Basically, the dosing changes if you're dealing with a gel where you're instilling a certain length. So usually half an inch or so is going to be enough to get enough coverage for the eye. And again, you're applying it very frequently. It's like 2 to 6 times a day, depending on how severe the eye infection actually is. Whereas azithromycin, this one you'd end up instilling 1 drop into the affected eye just twice daily, so it has a little bit better half-life, sticks around for a little bit longer, so that way you can get away with less frequent dosing. So that could be one benefit to your patients. Nope, no dosing, you don't have to know. But just know the principles there, right? Like know that typically ocular medications you have to give more frequently. Now, the thing you'll see here is that for most patients, even if you're not sure if it's viral versus bacterial, and again, most cases it's going to be viral, a lot of people will still prescribe erythromycin ointment anyway, because again, we don't see resistance to it. It's pretty cheap, and the nice thing about it is just having that ointment in the eye typically is just going to be pretty soothing for the most part. So it's going to help with a lot of the pain, irritation the patient's feeling, and so a lot of times we'll just prescribe it anyway. It's probably fine. This is probably one of the rare occasions where I'd say, go ahead and prescribe an antibiotic, even though we're not going to see a ton of benefit from it. There are other products that are non-antibacterial based that are out there, but we'll cover a few of those a little bit later on. But azithromycin, way more expensive, but you do give it less frequently, so one benefit, but not used very often. Then we have the Trimethoprim Polymyxin B. So this is used, you guys remember how Trimethoprim worked? Worked on which?
The P and PABA DHR.
Yeah, so just remember, it blocks folate synthesis, right? Blocking the effects of folic acid. Again, know that sulfamethoxyl is working on a different step, but this is also working here on folate synthesis. Polymyxin B, you guys remember how that one worked?
the lipo something?
Yeah, it basically kind of punches a hole right through the bacterial cell wall. Yeah, so it kind of opens it up, and yeah. So again, two different drugs. We haven't really seen this combination before, but this is a pretty common one. So if you hear Polytrim, that is a very common one that we're going to use there. So again, very frequent administration every 3 hours. Again, similar durations of treatment as other antibiotics we would do for like 7 to 10 days or so. We'll see that when we get to different disease states. But most indications, bacterial conjunctivitis. So again, if you're suspecting bacterial, this isn't one of the ones you are going to go with pretty frequently, we see. You can also use sulfacetamide. This works very similar to sulfamethoxazole. So again, if we were seeing that trimethoprim worked here to block dihydrofolate reductase, again, we're going to see our sulfonamides like sulfacetamide or sulfamethoxazole end up working here to block folate synthesis, right? So just note that you can see this one by itself. This one, again, nothing really special to note about it. Again, you may see some patients who have a true sulfonamide allergy already. They can react to this when given topically, so that could actually make their conjunctivitis worse. So just be aware of that. They have a previous sulfa allergy. Okay. Again, I'm only going through these kind of quick because we've already covered most of the basics of the mechanism. Previously, this lecture used to come before the antibiotic stuff, so that's why there's a little bit of overlap.
What you said about the adverse reaction, if they have a reaction, you would rather give what?
So if they have a sulfa allergy already, that could actually cause a kind of a local reaction for the patient. So you'd want to use something else. Yep. So you could use like the Polytrim, you could use erythromycin, whatever. All these options are going to be pretty much equal. Some of it's going to come down to how frequently you have to give it, how much it's going to cost your patient, different things like that. But in general, they're going to have pretty similar coverage. There's going to be some exceptions to that, and we'll talk about those in just a little bit. You also have Bacitracin. Again, this is typically given dermally. We'll talk about, I think we covered that a little bit in the dermatology section already. So you see Bacitracin ointment being given for wounds and things like that. You can also give it in the eye. Also works very effectively for that. Again, this is another one that comes as an ointment, so you'd apply as a 1/2 inch versus drops. So just be aware, like when you're writing those prescriptions, note what the dosage form is, so that way when you write the instructions, you're not going to write something goofy like drops, and then the patient's trying to drop out a gel, and it doesn't really make sense, right? The pharmacist might call you up about it, so you don't want that. Next, we have fluoroquinolones. So these guys are going to be, you don't want to jump to using fluoroquinolones for a typical bacterial conjunctivitis, right? You want to hold off on these because you do have a possibility for seeing resistance. They're also more expensive, and we want to save them for one specific type of bacteria. Do you guys remember any like specific gram-negative bugs you'd want to? Pseudomonas, yeah, so Pseudomonas is going to be a big one. So you usually like to hold off from your fluoroquinolones and use it for Pseudomonas. Does anyone know what type of what type of patients are more likely to get a Pseudomonal ocular infection? Contact lens wear. Yeah, so that's a big thing. So if you have someone who gets like a bacterial conjunctivitis and they wear contact lenses, again, have them throw away the contact lenses. Some people try to clean them and use them over again. Don't do that because they can have a risk for reinfection. But this is where your fluoroquinolones are going to be your big hits here because they have good anti-pseudomonal activity when given in these kind of high concentrations. And you guys remember how they work? DNA gyrase, topoisomerase rat. So they're inhibiting that, causing DNA strain damage in the bacteria. Perfect. So again, if you have corneal ulcer, also if you're thinking Pseudomonas, these are going to be drugs to go with. Note the kind of only unique real side effect here is that you can get some unpleasant taste. And why would you get a taste from a medication you're giving in the eye? Everything through the nose, the back of the throat, you're going to end up tasting that, right? So again, it all goes back to that nasolacrimal drainage. So also you can see a white precipitate that can form with a ciprofloxacin. So again, they may think, hey, what's this kind of grody white stuff? It's just related back to the drug, just once the rest of the fluid kind of evaporates off of it. You can just picture kind of showing there the mechanism here. We already covered that. So again, this is going to be preferred for corneal ulcers, or if you're thinking Pseudomonas, these are going to be the drugs to go with. They typically are very expensive, and we are starting to see some resistance to these drugs, even when they're given these high concentrations ocularly. So just be aware, hold off on these unless you really need to use them, especially if they are contact lens wear. They're going to be the highest risk for Pseudomonas. Okay. We also have our aminoglycosides. So you guys remember there's gentamicin, tobramycin. You guys remember the other aminoglycoside? Yeah, amikacin is the other big one. So typically you can find gentamicin is probably the most common ophthalmic variety you're going to see here. And again, still working on protein synthesis and inhibition. This is one of the ones that you'll see being given to babies when they're initially born in order to help prevent any kind of, or at least they're born vaginally to prevent any kind of infection from bacteria in the mom's vaginal canal or the birth canal. They will give gentamicin ointment. So if you ever see that kind of yeah, you ever see their eyes look all goopy right after they're born? I was curious about that, but that's what they're doing essentially. Do you have a question?
No, I just wanted to know which one it was.
Yeah, gentamicin is the most common one. Yeah. So again, this is one we don't use very frequently because as far as adverse reactions go, these can actually cause a corneal ulceration. So again, with the babies, we're only giving kind of a one-time dose because again, once they're born, like they're not going to be re-exposed to those same type of environments again. Hopefully, I can't imagine that situation. Try to put them back in. Maybe the first couple sleepless nights, I was like, can we just put her back in for a little bit? And it didn't work though. But yeah, so you can't see corneal ulcerations. That can be one significant side effect, and why we don't jump to using the aminoglycosides very frequently. Okay. Again, you can see some viral infections, and who do you think might be at risk for having a viral ocular infection with something like herpes zoster or something like varicella? I'm sorry, herpes zoster and also varicella. Any?
Older people?
Possibly older people, especially as their immune systems start to go. But then also think about your cancer patients, think about HIV patients that are more progressed, right? So those are things you worry about. And so again, with typical run-of-the-mill viral infections due to things like adenovirus, like you can't do anything about that. You know, certainly you might try some erythromycin ointment to try to help kind of soothe the eye, but it's not really going to help a lot with that viral infection. Instead, you know, just good supportive care for those patients. We'll talk about some individual ones we can do for these other types of viruses. Okay. All right. So, and again, so typical viral eye infections, again, just supportive care is the best thing for them. Either do like saline eye drops or artificial tears or something like that. It's usually going to be good enough for kind of managing some of those symptoms. So there's only two items I want to note here. Main ones being trifluridine and then also this Ganciclovir. Note that most of these other medications are going to be either oral or intravenous. So that kind of goes to show you that once these patients get some of these, like a herpes infection in the eye or a cytomegalovirus or something like that, like typically you need systemic therapy because you need to make sure you're getting high enough levels there in the eye, kind of from not just from the topically administered, but just systemically, they typically need kind of a lot bigger guns and using systemic therapy. But these are going to be the two topical ones we're going to talk about. I guess Ganciclovir is not really topical. We'll talk about that in a second. But so anyway, Trifluridine or Viroptic, this one is going to be working to interfere with that viral replication of their DNA by inhibiting thymidylate synthase. So basically what it does is it gets incorporated into the viral DNA in place of thymidine, and basically the viral DNA cannot elongate off of that. So it'll kind of attach onto the end of the DNA, can't produce any more DNA off of that, and it kind of leads to cell death or to viral death eventually. This one we're going to use most often for keratoconjunctivitis due to herpes simplex. It's the most common thing we'll be administering this for. And as far as side effects go, the only kind of unique thing here is the kind of punctate keratopathy you can see. So again, this is under a Woods lamp, using a black light to see, we'll talk about the fluorescein we use in just a little bit to see that, but that's what you can see as far as like kind of a unique drug interaction or side effect. And then we have Ganciclovir. This is going to work very similar to some of the other antivirals, where again it's going to be working to replace guanosine essentially to get incorporated to the DNA and prevent further elongation. Right, so it's kind of the most common way we have to fight some of these viruses. This one we're going to most often either use for herpetic keratitis or for the cytomegalovirus. This is probably the most common thing that I see for those really immunocompromised patients. And this one ends up being an intravitreal injection. That was that implant we mentioned before. They can actually place that and basically have this kind of drug-eluting material that will allow drug to be seeping out of it over a prolonged period of time. So that way the patient's getting really high concentrations for a long time, and they're going to be able to treat that infection pretty well. So again, if you were to imagine Ganciclovir coming in, getting incorporated, eventually it's going to get phosphorylated. That's basically this monophosphate versus diphosphate. Once it gets triphosphate applied, then it's going to get incorporated in that DNA and prevent any further elongation. And you'll see this works very similar to things like acyclovir or valacyclovir, like Valtrex. So they all have the same mechanism where they're just substituting in for the normal base pair and then preventing further elongation. Okay. And then occasionally you may need some ocular antifungals. This one's not very common, but natamycin would be the only one that's commercially available as an ophthalmic product. And so you can see, again, fungal infections on the rise due to having more immunocompromised patients. You may see this one very occasionally. Other patients you may see being at risk for fungal infections include those that have trauma. So imagine if you're in a car wreck or if you're being exposed to things like a lot of microbes in the soil and things like that get into wounds. That tends to be more of a site for fungal infections. Any kind of chronic ocular surface disease. So if you have kind of long-standing any kind of hardware touching the eye, that can be one thing. Contact lens wearers as well, and just general immunosuppression. So again, we'll also look at there's some topical steroids we can use in the eye. This will also make you more likely to have fungal infections because in general, corticosteroids, very similar to the natural cortisol we release from the adrenal glands, what do they do to the immune system? They inhibit it, yeah, suppress it. So you're going to see the same thing here when we're giving exogenous corticosteroids. Again, here you can see natamycin. No, most of these other drugs we're going to be giving either have to be specially compounded, or they're going to be something we're going to give either orally or intravenously. So again, if I highlight it, that's the one I want to note because we're just specifically talking about ophthalmic administered medications. We'll talk about these other ones later on. So again, this one's working by basically increasing the cell membrane permeability in the fungi. Again, fungus is going to have a different target than you'll see with bacteria than human cells, but this is going to increase that cell permeability and allow the materials to kind of leach out and then kill off the fungal cell. And you can see several different types of fungus we're going to be treating with this. It's not important to know which species specifically, just know that it treats fungal infections if you were to see it on a test. Okay, so whenever you have a patient who's presenting with an eye complaint, it's really important to make sure you do a visual acuity to make sure you can get what their baseline is and then see what any kind of follow-up is. Because again, you want to make sure that things are not getting worse for your patient. So always make sure you do that. Make sure you're documenting allergies. If they have any kind of previous visual acuities you've done or any kind of previous exams, make sure you can look at those if you have that kind of information available. And you always want to educate your patients that if they have any kind of worsening in vision, they need to come back and get evaluated immediately, right? Because that could be a sign that something else really bad's going on than what you might have been thinking originally. As far as administration of medications to the eye, the biggest thing you have to do first, wash your hands. They have to wash your hands. A lot of people don't do that. They skip that step, and guess what? They're reinfecting themselves. Don't want that to happen. So make sure to wash your hands. Basically, the ophthalmic products, they come sterile, and you want to keep them as sterile as long as you can. So don't have them touch it to anything, any kind of skin or anything like that. Keep the tips sterile as long as they can. And basically, what you're going to have the patient do is tilt their head back, and then you're going to pull down on the lower eyelid to help form a pocket, kind of opening up that cul-de-sac and getting it exposed there. Next, you're going to hold the dropper essentially with the other eye, or with the other hand, I should say, and basically without touching, then squeeze the dropper and place one drop into that pocket there. Okay. Now this is kind of the thing you might not have thought of, because before that, it's pretty straightforward. Okay, you just put your head back, put a drop in, no problem. The other thing you want to recommend your patients do, and this is to kind of a twofold thing. One, it helps to prevent systemic absorption by blocking off the lacrimal duct, and then also it's going to lead to more time where that drug is in the eye to actually work. And so you want them to have basically tilt their head forward and make sure they are putting their finger right in the corner there so they can block off that lacrimal duct. Okay, so again, blocks absorption. It's going to help to keep the drug around for longer, usually 2 to 3 minutes or so if they keep the eye closed, and then if they have any excess, they can wash it off. And then again, do the same thing for the other eye. Okay. Now, what if you have to give multiple drugs? What do you think you should do? Yeah, usually give it a period of time where you're going to be, usually you don't find things where drugs will interact and inactivate one another, like you saw for some of the derm stuff. But again, give it a few minutes before, between different drugs when you're applying these. All right. So looking at drops versus ointments, you're going to find that ointments tend to be better for kids because, again, if you imagine if you're trying to give ocular medications to kids, how easy is that going to be? Not easy, right? So the nice thing, at least with an ointment, even if you just get it in their eyelashes, it's going to be sitting there long enough, at least make enough contact where it can still be effective. So that can be one thing we'll do for kids who do poor compliance. And just note with the ointments, so they may blur the vision. So for about 20 minutes or so until it kind of washes away. So just make sure you educate patients on that. It's not their disease getting worse. It's just the factor of the ointment itself. With gels and ointments, again, it's a similar process, but basically you're just going to squeeze out a ribbon of the medication, usually ½ an inch to an inch, essentially, into that pocket. But there's no need to cover the lacrimal duct for those drugs because they stick around on their own anyway, just because they're thicker. Now, patients who have contact lenses, and while they're having conjunctivitis, they should discontinue use, so switch them over to glasses if they have some. And then once the eye is not inflamed anymore and there's no discharge for 24 hours, that's when we recommend they can go back to using their contact lenses. Obviously, they should discard the old ones. We don't want to try to clean them off or anything like that and try to be frugal. Just go ahead and get a new set out. And then also try to get rid of any eye makeup. I apologize if you have any really expensive eye makeup, if the patient has any that they need to get rid of, but it's possible for reinfection, right? I had to throw out a lot of mascara last year because I got really nasty conjunctivitis. Just kidding. Just kidding. Okay. Does anyone know what to do if you have super glue in your eyes? Anyone ever heard of a kid accidentally gluing their eye shut? Did you try to pry it open? That would kind of hurt. You don't want to do that. Typically, what you can do is actually you can still use erythromycin ointment. Basically, the oil base that that's in can actually help to dissolve the super glue. So you can basically just apply it on there, and eventually it'll kind of free itself up. Give it 20, 30 minutes or so. That's what we do if you had a kid that glued their eye shut coming into the ER. We've actually had one case where we had a kid who they were playing. This is back in like rural Duval County, so kids didn't have anything better to do than throw back forth a bottle of drain cleaner, like Mr. Plumber. And so they're just throwing it back and forth to each other. Cap ended up coming off, and kid got some in his eye. And so if you know anything about drain cleaner, it's very, very caustic, very, very dangerous to the eye. So we end up having to bring him into the ER, and we need to irrigate it very, very with a lot of saline, And so one of the things we ended up having to do is because this kid was fighting us because he's in a lot of pain, he's freaked out, he's worried. We actually ended up having to give him a sedative just to knock him out long enough to where we can put in a device called a Morgan lens. Anyone ever heard of a Morgan lens? What is that? Yeah, it's like a contact lens with like a little tube coming off. It looks really freaky when patients have it in, but essentially we were able to knock the kid out with ketamine, get him still long enough to put a Morgan lens in, and then we could flush saline through that for a period of time until we got the pH of the eye back to normal. So sometimes you have to kind of go to kind of above and beyond to get your patients the care they need.
How long does that take?
To flush it out, probably 30 minutes to an hour or so, just continuous flushing. Another thing you can do sometimes if you need to flush the eye and you don't have access to a Morgan's lens, you can actually take a nasal cannula and put it over the bridge of the nose and hook that up to an IV bag, and that'll actually run. Yeah, so little tips you can do there. So anywho, so moving on. You guys okay? Do I need to give you a break? 5 minutes. Let's do 5-minute break, and we'll come back and then continue on. So the other thing you see with a lot of patients with allergic conjunctivitis is that you get this kind of typical cascade of inflammation that occurs here, and a lot of this is due to histamine. So again, you'll find that this is one of the main targets we're going to be shooting for, and as far as medications to deal with this inflammation are antihistamines we're going to use here. They get released by a lot of mast cells and basophils when you're having an allergic reaction, and you're going to see these IgE antibodies forming here pretty quickly, along with these other kind of inflammatory cytokines which kind of worsen the inflammation you have there. So basically what you end up seeing is that due to things like histamine, platelet activating factor, leukotrienes, all kinds of things that happen due to this cascade, you end up seeing a lot of vasodilation, a lot of swelling, redness, and itching, right? So for everyone's experienced some sort of allergic conjunctivitis at some point in their life, not super comfortable, and so there's some things we can do to prevent that. So again, imagine this allergic cascade. We have this degranulation of your mast cells. They're due to some sort of antigen binding to it. You're going to have lots of prostaglandins, heparin, tryptase, all sorts of other things. But basically, you're going to find there's vasodilation that occurs here. So again, it's going to cause the redness. The capillaries end up becoming more leaky, so fluid comes out, and that's where you get a lot of that edema. And then the histamine especially causes a lot of that itching you feel. So what we can see is we use H1 receptor antagonists. Do you guys know where you find H2 receptors at primarily? Yeah, so H1 and H2 receptors we're going to primarily talk about. H2 is in the gut, right? So when we talk about things like Zantac or like Pepcid, things like that, those are H2 blockers. We're mainly going to be focusing on H1 blockers when you're dealing with allergic symptoms, okay? So that's an important distinction to make there. H1 blockers work for allergic symptoms. H2 blockers work for GI stuff, okay? So anyway, so basically we're using these antagonists. Don't really get worried about this inverse agonist thing, but just remember that it is working to block the effects of histamine. Actually does a little bit of the opposite effects essentially, but still competitive here. And what they're going to do for us is they help to decrease that capillary dilation, decrease the itching, and decrease the swelling. So some of the ones we have are antihistamines in as far as in this category. We have things like azelastine, we have imidazole, we have apinestine, ketotifen. This one's actually available OTC. This is the only one at least I'm aware of that's available OTC. And we have olopatadine or Patanol. Now, when I say MCS, that stands for mast cell stabilizing. So that means it keeps some of those mast cells from degranulating in the first place, right? So by having that, you can help to hopefully prevent kind of further worsening of the inflammation if you have some of that effects there. We're going to find there's specific mast cell stabilizers, but these are going to be the main drugs we're going to be using here due to their antihistamine effects. So again, you're going to dose these typically 1 to 2 times a day. Oftentimes, these are going to be dosed as needed for when the patient actually has the symptoms, or if they know that a certain exposure is going to cause these symptoms, they can use it kind of as a prophylactic. So for instance, I know if I go around cats, I'm going to be sneezing, I'm going to have lots of conjunctivitis, it's going to be really bad, right? So if I know that I'm going to be exposed to cats at some point, then I can go ahead and take medicine beforehand, or I can take those eye drops beforehand and prevent the symptoms from occurring, right? So before the histamine gets started in the first place, I can kind of block the effects. But the onset here is going to be pretty quick, within a few minutes. And whenever you're giving these medications, you need to give them a few weeks, kind of let the patient really try it out, get a good test run to see if it's going to work for them or not. So usually 2 weeks or so. If it's still not working for them, then maybe switch over to something else. As far as adverse effects go, not a whole lot here. Maybe some ocular irritation like you see with a lot of the other drugs. And then one other thing you're going to find that with our H1 blockers, in general, you're going to find these typically are drying. Usually because they have a little bit of anticholinergic effects, meaning they kind of block the effects of some of the acetylcholine. So you may see some increased ocular dryness. Just be aware you can see that with these drugs. Again, no significant drug interactions because they're only being applied to the eye. And you are going to see these are going to be your preferred drugs over specifically mast cell stabilizers. And the reason for that is because if you're having an acute allergic reaction, so if you're already tearing up and having lots of redness and itching, those mast cells have already degranulated, right? You really need to take those mast cell stabilizers before the insult has occurred, whereas these drugs work after the insult has already happened, right? Because they're still blocking the effects of the histamine that's already been released, essentially. That makes sense? Hopefully. All right. So again, we have specific mast cell stabilizers. Again, these are going to help to limit the release of histamine, prostaglandins, and other inflammatory mediators, and they basically dampen the release of all those inflammatory cells, essentially. But again, they only work prior to them actually being degranulated in the first place. So we have 3 here. We have cromolyn, we have lidoxamide, and this netocromil. Again, I'm going to tell you that I probably see these being used very, very occasionally, not nearly as much as the H1 blockers. So really just kind of saying these here just for kind of completeness sake. Again, these are going to take a while for them to work, so probably up to 2 weeks before you can assess full efficacy. Again, these are not useful for acute symptoms. If they're having an acute symptom right now, they need to use an antihistamine instead of a mast cell stabilizer. And these are typically requiring more frequent dosing. Again, not super ideal for these patients. So really the only time you're going to use them if patients cannot tolerate antihistamine, they have an allergic reaction, or they can't have access to it for whatever reason, these would be kind of your fallback drugs that you can use for those patients. Okay. We can also have some vasoconstrictors along with some antihistamines. So basically a vasoconstrictor, that's going to help to deal with a lot of the edema and a lot of the redness you're going to see with these allergic reactions. Not super great for dealing with the itching necessarily, but you ever seen those commercials for you have red, dry eye, Ben Stein? I'm probably aging myself pretty bad there. But anyway, so these are going to be good as a vasoconstrictor, deals with the edema, deals with the red eye essentially. So some agents we have here include things like tetrahydrozoline, we have nefazoline, and then we have this phenyramine in combination with nefazoline. So this is actually a combination of antihistamine plus a vasoconstrictor there. And so essentially these are working on alpha-1 receptors locally to cause constriction. So you guys are familiar with alpha-1 versus alpha-2 receptors? Has ever covered that before? So alpha-1 is primarily found on blood vessels, right? So this will be important when we get back to talking about cardiac stuff. But alpha-1 receptors cause vasoconstriction when they're activated. And so by giving a vasoconstrictor that activates these alpha-1 receptors, that's what's going to cause them to squeeze down and prevent a lot of that edema and redness. Okay, so just be aware of that. So these are good for short-term use. You can actually find that over time, remember that concept of receptor upregulation and downregulation? Right, so if I'm constantly activating a receptor, what does it want to do, downregulate or upregulate? I'm constantly pushing you, poking you, what are you going to want to do? You're going to get away from me, right? So you're going to kind of downregulate. You're going to have fewer receptors available. What you find is that if you have chronic use of these vasoconstrictors and then you were to take that away immediately, you have fewer alpha receptors available, at the site to actually bind to things like norepinephrine or epinephrine, and so you end up having a rebound hyperemia. Basically, the vessels open wide open, and they're going to get very, very red, very, very swollen eyes, essentially. Okay, so that's one of those things where anytime you're using these vasoconstrictors, and we'll see this come up again when we talk about nasal vasoconstrictors, you want to use them for short courses, again, because you can see rebound effects here. And again, if they don't have improvement, again, most of these products are available over the counter. The problem with self-medication for these patients is that oftentimes they will treat themselves and not realize that there could be something else going on, right? So that's why you want to recommend that if they don't get better within 72 hours, they need to come in for an evaluation. So just one thing to note here, there's also alpha-2 receptors. This will be more important when we get into in the cardiovascular section, but just note that these vasoconstrictors I'm talking about, they primarily are alpha-2 agonists, essentially. But you can find that when you have high doses being applied locally, you lose a lot of receptor selectivity. So they can still interact with these alpha-1 receptors that cause that vasoconstriction. The problem that we run into with some of these drugs is that if kids get into them, because again, they're likely to get into lots of types of drugs, you end up seeing this alpha-2 effect. And essentially what alpha-2 does when it's activated in the brain is it shuts down the sympathetic nervous system, essentially, right? So if a kid were to drink this, they would all of a sudden get hypotensive, they get bradycardic because they don't have enough norepi and epinephrine being released from the sympathetic nervous system. So that's just one note to keep that in mind, that some of these over-the-counter medications can be very, very deadly if kids get into them. So we also have some NSAIDs, or non-steroidal anti-inflammatory drugs, that we can use to help with some of this inflammation as well. These are not going to be used very commonly for outpatient use. These are going to primarily be used around ophthalmic surgeries, as we'll see here in a second. Essentially what you see, and this is works, do you guys know of any other NSAIDs you can take like orally? Ibuprofen. Yeah, it's like a more prescription one. It's kind of one of the generic or over-the-counter one you can get. Yeah, so Advil's Motrin or ibuprofen. Yeah, naproxen's the other big one you're going to see over there in the over-the-counter forms. These work the same way. Essentially what you see is that when you're having inflammation, there's kind of two main pathways that happens. You guys ever heard of arachidonic acid? Pathway here. Okay, so essentially this is a precursor for a lot of inflammatory mediators, essentially. So when you have a cell that says, hey, we need to start this inflammatory cascade, it's going to have cyclooxygenase, or this COX enzyme, that gets ramped up. And so you can find there's a couple different varieties. You have this COX-1, COX-2, and they're going to generate things like prostaglandins and a lot of these inflammatory mediators. Now, there's two primary COX varieties. We have what we call this constitutive COX-1 enzyme, and then we have this inducible COX-2 enzyme. And so what do you think the difference is between an inducible enzyme versus a constitutive? Sort of, yeah. So constitutive means it's always being expressed. You always have COX-1 that's around because it's really important for things like hemostasis. It's really important for things like protection of the gastric mucosa. On the other hand, though, when you have an acute inflammatory event, so say for instance I sprain my ankle, I have an acute site of inflammation happening there. This is when you ramp up production of COX-2 in order to help produce those inflammatory effects. So this is important because this will kind of educate you on a lot of the side effects you see with these NSAIDs. Essentially, the drugs that we use are non-specific for COX-1 or COX-2, and so you can see that there's going to be lots of side effects associated with using these. And so, has anyone ever heard of someone having a gastric ulcer due to using things like ibuprofen? This is why. It's because you're actually inhibiting this constitutive variety that's good, that we want to have activity of, but it blocks the effects of it anyway, right? And so again, that's why we see some of the side effects. So just note, these cyclooxygenase gets inhibited by these NSAIDs, and that prevents production of a lot of prostaglandins and other inflammatory mediators. Okay, so that's how it deals with inflammation. So we have a couple of these that are available. We have things like bromfenac, diclofenac, flubiprofen, ketorolac, or ketorolac, as you might hear it being called. Yeah, a lot of people say ketorolac, but toradol is, yeah, this is the Ocular, is the ophthalmic variety, and this nipafenac. Again, so all of these are available as ophthalmic NSAIDs you can administer, and you're going to find these are not routinely used for things like allergic conjunctivitis because they're not really fixing the problem, which is mostly like that histamine release that we saw previously. Instead, these are oftentimes used around ophthalmic surgeries, usually in the post-operative setting to help deal with a lot of the pain you see there. And sometimes if patients have really severe allergic conjunctivitis where other meds are not working, sometimes we use NSAIDs. Now, we don't like to use them chronically because they can cause keratitis to occur, and they can also raise intraocular pressure, right? And so it's going to be important when we talk about glaucoma. And so this can be one of those type of patients where you may not want to use these drugs if they already have high intraocular pressure to begin with, right? Okay. Have you guys started covering any ophthalmic stuff? You talked about glaucoma already? All right, good. You talk about treatment of glaucoma? Okay, we'll get more into it here as well. Okay. As far as kind of the most heavy-duty anti-inflammatories you can have for the eye, we have our glucocorticoids. Okay, so again, does anyone know how our normal kind of stress hormones work in the body? We have like cortisol being released from the adrenal glands. How do they work? So they actually work just like other hormones, just like estrogen or just like testosterone. They have to get down to the nucleus of the cell, right? And they affect gene transcription. They affect protein production. And so by doing that, you're going to have the kind of the most top level means of inhibiting inflammation. So glucocorticoids are the most potent anti-inflammatory drugs we have. They're also most prone to side effects because they work at such a high level. But basically, what you see is these are going to work at the site of the nucleus. They block production of a lot of these inflammatory mediators, and they are very good at being anti-inflammatories. They do take time to work, though, because they have to work on the cell's nucleus to change that production. You know, if they've already started producing a lot of these inflammatory mediators, you can't really do anything about that with the glucocorticoids. So what we're going to use these for are they're having very severe ocular allergies. In some other cases where you're having a lot of inflammation. So you see these more used in cases where patients may have like autoimmune conditions, things like that, where basically the immune system's attacking the eye. These can be very useful to help block that. And then it can also be either applied topically or potentially intraocularly. The reason why we don't use these very frequently is because there's actually a decent number of side effects that come about from them. Again, just to give you an idea what glucocorticoids are doing more globally, you can see here how they can affect inflammatory cells to decrease their numbers, decrease the amount of cytokines they're releasing, all of that good stuff. And they can also help with doing things like decreasing mucus secretion, help with a lot of vasodilation that occurs. So they kind of work at the top level to block inflammation. But what we see with ocular glucocorticoids is that when you're giving them, you want to save them for refractory symptoms. They've failed other meds because they can work to cause cataracts to form. It's not good. They can elevate intraocular pressure, especially if they have a family history or if they already have glaucoma. You see that they are immunosuppressive, so you're more likely to have infections, both viral, bacterial, and fungal. They can delay wound healing. So there's already damage done to the eye that's going to delay that. And then it can also cause corneal ulcers. So you really like to hold off on using these unless you have a really specific indication. So if you're working like in the urgent care or if you're working in like the ER, like you guys are not going to be the ones to prescribe these. These are oftentimes what the ophthalmologists you're consulting are going to come in and prescribe because these have so many side effects associated with them. You really don't want to mess with them unless you know what you're doing. So unless you're working in the ophthalmology office, you probably want to avoid them. So we have a few that are listed here. So things like dexamethasone. We're going to see this one come up again when we talk about oral glucocorticoids. You have prednisolone. We have this difluprednate. We have this fluorometholone, loteprednol, romexolone, and triamcinolone. This one actually comes as an intravitreal injection. The stars here, just note what we call soft steroids. They're kind of a newer generation that actually have less effects on less a risk of increasing intraocular pressure. So that's kind of one benefit there. It might be more safe to use for your glaucoma patients. Okay, so moving on, other therapies we can use for our dry eyes. So again, that was a commercial. Anyone ever see that? Anyone? Maybe under the age of 25 in the room? No, nothing?
I've seen them.
Okay. On Nick and Night, maybe? Just kidding. Okay. Most people probably don't know what niconide is either, so that's okay. So we know that lots of things can affect that precorneal tear film. Chemical burns, we see that in the tox world pretty frequently. Blepharitis, corneal dystrophies, all sorts of things can cause kind of this chronic dry eye. And they can affect the ocular surface, lead to abrasions. You can see tear composition change. There's also a lot of autoimmune conditions that can do this as well, including things like rheumatoid arthritis, vitamin A deficiency, Stevens-Johnson syndrome. So lots of things can cause pretty severe dry eye. And so some things we can do for that is, one, you want to treat the disease first, so whatever's underlying, you want to fix that if you can. And then we can actually do some physical intervention. So we mentioned you can do punctal plugs, where you can actually put that into the lacrimal ducts to block a drainage of tears, which is good. Or you can do surgical occlusion. And then more often than not, the easier thing to do is going to be using tear substitutes. These are most often going to be either hypo or isotonic solutions, usually saline based, that you can put into the eye. So this includes things like your balanced salt solution, or if you ever see BSS, that's a common one. We have carboxymethylcellulose. A lot of these have thickeners put in them as well, so they help to stick around for longer. So that way, it's kind of helping to do the job of what your tears would be doing otherwise. It can be useful. Polyvinyl alcohol, usually called artificial tears. So a couple different varieties there. They're all available. Most of them are over the counter. You can use pretty easily, and patients can get a hold of. And then one interesting drug we have to treat dry eye is going to be an immunomodulator called cyclosporin. This is actually an immunosuppressant. We can actually see sometimes used for patients with transplants if you use it systemically. We can also use it in the eye, though, because it actually helps prevent production of things like interleukin-2, which actually blocks T-cell activation. So if the patient had dry eyes due to an autoimmune condition, you can use this potentially to block that T-cell activation and help to restore normal tear production. So when you give it an eye, you see decreased inflammatory markers, which is good. You have increased tear production and improved vision and comfort for your patients. So again, this could be something where if they fail other therapies, this is kind of a nice backup drug that you can potentially use. Again, you can see some ocular burning, some foreign body sensation, and blurred vision associated with this one. Other than that, it's pretty well tolerated. So Restasis is the brand name for that. Okay, so any questions on that section? I'm going to try to blast through this glaucoma section real quick here. So glaucoma is characterized by high intraocular pressure. The problem with that was why do we care about if we have high intraocular pressure? Vision loss due to? Yeah, so you see optic nerve damage occur over time just due to that high pressure. So we don't like that. It can cause irreversible blindness for your patients, which is no good, right? So we have two main varieties. There's going to be open versus closed angle glaucoma. Usually closed angle glaucoma is secondary to like trauma or some other kind of mechanical problem going on with the eye. Open angle glaucoma, this is what we're going to focus on because this is where the drugs are going to be most effective here, okay? The targets, the two things we're going to try to do with our medications, it's important to understand which mechanisms each drug is kind of focusing on, is we want to decrease aqueous humor production, right? There's nothing funny about that. We also want to increase that outflow through the trabecular meshwork, okay? So either decrease production or increase outflow. Those are the two main ways of attack that we can treat glaucoma. So again, normal ocular pressure anywhere between 10 to 21 millimeters of mercury, and we'd call that ocular hypertension if you start to get above that. And obviously, open angle glaucoma is usually caused by either that increased production or decreased outflow of that aqueous humor, versus that angle closure glaucoma usually is due to a blockage of a drainage canal. It's usually something that's going to be requiring surgery, versus the open angle can just require drug therapy for the most part. So I see the differences here between open angle, where again we can see that here where the actual aqueous humor is being produced, you can see it kind of flowing through here and eventually go out into the drainage canals. When you have an angle closure glaucoma, you see this being blocked off, and so that's going to lead to that really high pressure. That's usually really painful kind of glaucoma. Usually open angle glaucoma is the patient doesn't even feel it, right? That's why they have to get routine checks, or if they have a family history of it, because you don't really feel that you have intraocular hypertension. So we mentioned that our goal here is we want to prevent progressive optic nerve damage and try to minimize the risk with some of our side effects with our systemic therapy we're going to see here. So again, all these drugs we're going to get for glaucoma are going to be topically administered, but because of that absorption through the nasolacrimal duct, you do have to worry about systemic effects. We want to minimize those where we can. Okay, so we're going to categorize these based on their mechanism and what they're going to do for us. So here we're going to see that we have prostaglandins. These are going to be some of our first-line agents, and these are going to be working to increase aqueous outflow. Okay, we have our alpha adrenergic agents, which these are going to activate alpha receptors, as we'll see in a little bit, and then we'll have some cholinergic agonists. You guys know what type of receptors these might work on? Acetylcholine receptors, yeah. So primarily we're going to see some muscarinic activity, right? There's muscarinic and nicotinic acetylcholine receptors. Hope that's ringing a bell for some of you guys somewhere back in the day. Don't worry, we're going to talk more about receptors and a lot when we get to the cardiovascular section for sure. Okay, and then we can also have some drugs that work to decrease aqueous production. Notice there's a little bit of bleed over here where our alpha adrenergic agonists are going to be working here as well to do this. This is where our beta blockers are going to come into play. Can you imagine what type of receptors they work on? Beta receptors, right? So these are going to be useful to help decrease aqueous production. These are probably also considered first or second line depending on your patient. So really the prostaglandins and the beta blockers are kind of your first line drugs. And then we'll also deal with our carbonic anhydrase inhibitors. We'll go over these in more detail in just a second here. So prostaglandins, I like these to be our go-to drugs. Basically, they're going to be trying to mimic the effects of PGF2 alpha, which is kind of an endogenous prostaglandin that we have naturally, and basically trying to increase levels of that. So basically going to bind those prostaglandin receptors and will lower intraocular pressure by trying to increase the outflow of the aqueous humor. Okay, so increased outflow. So if again a test question came up and it said, hey, which one of these drugs works by increasing outflow of aqueous humor? You say, hey, prostaglandins would be one of those answer choices, right? And we don't know the full mechanism for some of these drugs. We just know that they work, so we're just going to kind of go with that. Some of it may be due to ciliary muscle contraction, changes in that trabecular meshwork. It could be several things that are going on there. But the notable thing here are the agents we have available, including latanoprost, we have travoprost, bimatoprost, and tafloprost. Okay. Notice here we have another brand. Anyone ever heard of Latisse? What is Latisse used for? Eyelash elongation. Yeah, we'll talk about what that is in just a second. As far as adverse reactions go, you can see some conjunctival hyperemia, you can see some ocular irritation, and then also note this change in eyelash length, usually elongating, and then also change in iris color. So I don't know if anyone's ever used Latisse in here, but does anyone know what can happen to your eye color? Turn to brown. Yeah, absolutely. So I'll show you a picture of that in just a second. But again, the nice thing with the prostaglandins is they limit systemic side effects. This is why I like them as a first-line drug, especially if the patient already has brown eyes to begin with. These are really good drugs to go with. But again, it's always a conversation to have with your patients. If I had glaucoma and the doc was like, hey, this drug might turn your eyes brown, I don't really care, whatever. Especially if you're an older patient, like I'm not trying to go after the ladies by any means. But for some patients, that could be a really significant thing. If they have nice, pretty blue eyes, you may not want to use these medications first line.
So it's not reversible?
No, typically not reversible, at least from what I've seen. So may or may not be, depends on the extent of the change. So you can kind of see here, this lady had prostaglandins put in this eye versus not in this eye. So again, this is the original eye color versus how kind of dark brown. It's not every patient, but some of them are at risk for this eye color change. It's hard to know who's going to be more at risk than others. But just note the changes in eyelash length before and after. So again, pretty significant. That's why some people use this more as a cosmetic product in order to elongate their eyelashes. So, but again, you need to educate patients. Hey, if you're going to use it for this purpose, just know it may change your eye color, right? You can still have some local effects that are happening there. So again, mainly going to be used for glaucoma, possibly for this eyelash elongation. But note here, you only want to use it once daily. Again, that's another benefit of the drugs. You only have to give it one time a day. But do not exceed that. Don't try to give more. More is not always better because this can actually end up inhibiting that effect and actually raise intraocular pressure, kind of paradoxically. Next up, we have our beta blocking agents. And so again, as you might imagine, these are blocking beta receptors. And so this is going to be working on the ciliary body epithelium. You're going to see there's less catecholamine activation. So things like epinephrine, norepinephrine can activate it. And so you're going to see decreased cyclic AMP. You guys remember we talked about cyclic AMP a little bit, right? And so then you have less aqueous humor production. So prostaglandins work to increase outflow. Beta blockers are working to decrease production. Now note here, we have beta-1 selective versus non-selective. So we have beta-1 receptors. The other type of beta receptors? Stands to reason we have beta-1 that we'd have beta-2, right? So beta-1, where do you find beta-1 receptors primarily? The heart's going to be one of the big places, right? So the heart, that controls a lot of the chronotropy, the inotropy of the heart is with beta-1 receptors, right? That's why if a bear pops out at you and you have your sympathetic nervous system being activated, it affects beta-1 receptors, your heart starts pounding, right? You also have beta-2 receptors. Anyone know where you find those? I'm sure my respiratory therapist might know. Find those in the lungs, right? Beta-2 receptors are very important for causing bronchodilation, right? That's why we use albuterol or use our inhalers when we have an asthma attack, because it helps to relax the bronchial smooth muscle. So, problem is if I give a beta blocker, say I have someone who's an asthmatic, and they need to have that beta-2 activation around to prevent an asthma attack, if I give them a non-selective beta blocker, and say I were to give it orally, it's not going to tell the difference between a beta-1 receptor in the heart and a beta-2 receptor in the lungs, right? So that's why you see with non-selective beta blockers, asthma is a relative contraindication, okay? It's not everyone, but potentially if they're having an asthma exacerbation and they try to use their albuterol, it might not work as well, right? Because those receptors are already being bound up. That's why we like to use beta-1 selective agents where we can, especially with asthmatic patients, to prevent that interaction, okay? So again, if I were to say which one of these drugs would be contraindicated for an asthmatic patient, I may put on there something like timolol or cardiolol, a non-selective beta blocker, and you need to pick that one out as being non-selective versus being selective. Okay. So we have betaxolol as our beta-1 selective agent, and we have a couple non-selective like cardiolol, timolol, and levobunolol. Okay, so the LOL on the end there kind of gives it away as being a beta blocker. Again, non-selective tends to be more efficacious, but you see more side effects. So the big thing you see with these drugs is that if you don't block off that nasolacrimal drainage, you can see systemic effects here. So one of the big side effects you see with beta blockers is bradycardia and hypotension. So you can actually see that with these drugs. Even if I'm giving a drop or two in the eyes, I can still see systemic effects from that. So that's why kind of worry about that. That's why you make sure you're giving it appropriately and kind of blocking off that drainage for a few minutes. Okay. Can also worsen heart failure for patients who are required, have kind of poor left ventricular function, cause heart block, increased airway resistance, and asthma. So those are the patients you got to be worried about. Just remember, use when to use the beta 1 selective versus non-selective. So again, kind of talked about this already. Just note that non-selective affect both receptors equally, but the selective beta blockers are going to primarily block just beta 1. Okay. Next, we have our alpha agonists. So I kind of mentioned those alpha 2 receptors previously, and we said that those help to kind of block the effects of the sympathetic nervous system and actually decrease the amount of catecholamines that are outflowing there. So what you're going to find is that they work both presynaptically to decrease the catecholamine flow, so that helps decrease aqueous humor production and increase outflow. And then postsynaptically, you're also going to find that helps decrease aqueous production. So just note that alpha 2 agonists are going to be working kind of on both ends of the spectrum here, whereas the prostaglandins only worked on one, beta blockers worked on the other. This works on both, which is nice. Now we have 2 drugs here. We have aproclonidine and then brimonidine. Basically, you're going to find these are pretty well effective. If you did have systemic effects, though, due to absorption, you can see things like bradycardia, hypotension associated with this. So those would be some side effects to watch out for. And so you're going to find these are going to be contraindicated in kids less than 2 because they tend to be more sensitive to these effects, because you can see CNS depression and potentially even apnea. It can actually have such significant effects on the sympathetic nervous system. You can see respiratory depression there. And then also we see limited other systemic side effects, usually for more adult patients, mainly due to the fact they have less blood-brain barrier crossing. They tend to be ionized at physiologic pH. That's kind of one of the benefits here. We'll see some drugs when you get to the cardiac section that are alpha-2 blockers, like clonidine. I don't know if anyone's ever heard of that one. But we'll talk about that later and how that can have these very similar effects. Then we have our carbonic anhydrase inhibitors. These are going to be kind of, I would say beta blockers, prostaglandins, kind of like your first / second line kind of agents to go with. Alpha 2 agonists probably kind of second behind that, and then carbonic anhydrase inhibitors probably going to be third. So these are going to kind of be the less preferred agents. But basically what we're going to see is these work to block the enzyme carbonic anhydrase, and so this is really important for converting CO2 in water into bicarbonate and vice versa. This will be really important in the kidneys as well, because these drugs will actually work as diuretics. But they're going to be working to decrease that fluid transport, decreasing the production of the aqueous humor, and then thereby decreasing the intraocular pressure. We have dorzolamide and brinzolamide as our 2 carbonic anhydrase inhibitors. You'll notice that the biggest adverse effects here are bitter taste, stinging after administration. So a lot of people don't prefer these agents, mainly due to decreased efficacy and just kind of unpleasant feeling. So this is a little bit of a busy slide here, but basically if you were to see basically the aqueous posterior chamber, this is basically where the aqueous humor is basically flowing. Just note that you're going to find that this enzyme, carbonic anhydrase, Ca here, converts CO2 and water into bicarbonate. And vice versa, it can change bicarbonate back into CO2 and water. I'm not going to get super into detail on here. Just note that by blocking that effect, you're kind of blocking the flow of aqueous humor in this direction. Okay, so you're kind of blocking that when you have a carbonic anhydrase inhibitor, so less aqueous humor is produced, less intraocular pressure. Okay, that's kind of the extent of what I want you guys to know. Okay, and then also kind of lower line agents we have here. We have our cholinergic agonists, and so these are working specifically to basically activate muscarinic receptors in the eye. So again, when you have acetylcholine receptors, you have 2 main varieties. You have muscarinic and nicotinic, right? Does anyone know where you use a lot of nicotinic receptors? Basically what makes your muscles move, right? So it helps communicate from the CNS down to the muscles, that neuromuscular junction. Those are nicotinic receptors. You guys know what type of drug binds to nicotinic receptors? Nicotine, yeah, absolutely. That's the first thing we found that bound to it, and that's why we call them nicotinic receptors. But the muscarinic receptors are what we're going to be more focused on here. Again, think parasympathetic nervous system, think muscarinic receptors, right? Think acetylcholine, okay? So anyway, we have a couple agents here, and basically by activating those muscarinic receptors, are going to cause that ciliary muscle contraction, and this will actually help to increase outflow of the aqueous humor. Okay. You have things like acetylcholine, which again makes sense because this is kind of the natural ligand that binds to those receptors. This is more going to be used in the surgical setting. A few that we can use other than that, though, we have things like carbachol and the pilocarpine. Now, a lot of people don't like to use this because you'll note, especially if you kind of compare the sympathetic versus parasympathetic nervous system, if you think somebody who is having overactivation of the sympathetic nervous system, they have a lot of epinephrine, a lot of norepi, what happens to their pupils? They dilate, right? So you see the opposite effect here because now we're kind of synthetically activating the parasympathetic receptors, and so we're going to see meiosis happen here, right? And so that can affect accommodation as well, and so they can have blurry vision, not really able to see that well. So you can see why it would not be a preferred item for these patients versus things like prostaglandins that really don't cause any issues like that. But again, they're going to fix small pupils, it's myopia, have a difficulty seeing for the most part. There are some combo products that are out there. This is nice because it combines multiple agents and allows for some synergy, allows for fewer drops having to be administered. So sometimes you might see things like brimonidine and timolol, brinzolamide and brimonidine. So it's just more of a convenience for patients, but it may be more expensive. So it may be more fiscally responsible for them to use multiple drugs. Just depends on the situation. Okay, so the question is who to treat. Basically, if we have patients without risk factors, you just monitor until their intraocular pressure, even if it's high, you still monitor until basically they start to see some glaucomatous changes in the optic nerve, things like that. But if they have risk factors or family history, you just go ahead and treat them anyway, right? Because you want to go ahead and get that started early because you know they're going to be at higher risk there. Typically, you're going to start with a prostaglandin analog or a beta blocker. Again, you have to have that conversation and say, hey, you have really nice blue eyes. Do you want to keep them that way? There's a small risk of them turning brown with this drug. They may say, hey, no way, Jose, let me use a beta blocker instead. Okay. So again, think about your patient, think what drug is going to be better for them based on their specific situations, right? So typically, you can start therapy in just one eye to determine both efficacy and tolerability. That could be one thing you can try doing. And in general, the goal is to drop your intraocular pressure about 20 to 30%. Okay. So you can start with a prostaglandin or beta blocker. If those are not working, you can add on an additional drug, usually either like carbonic anhydrase inhibitor, cholinergic agent, something like that. So think about different agents you can add, or alpha-2 agonist. Okay. So any questions on glaucoma? Okay. So again, if a question came up and like patient said, hey, they were on latanoprost, they're on a prostaglandin, was ineffective, what would be the next line agent you want to move them to? And say, okay, well, my patient might be asthmatic. You might say, okay, I'm not a beta blocker, let's go and do an alpha-2 agonist, right? So those are kind of the questions in therapy you might have to come across on a test, right? So think about those sort of things. Okay, so just a few kind of miscellaneous ophthalmic drugs you run into. We have ocular anesthetics. Essentially, these are going to be working. And again, if you think about how neuronal transmission occurs, how do action potentials get propagated down a nerve? It's in one direction, absolutely. What ion channels are required to send that transmission? Sodium. Sodium's a big thing, right? So that's where you see those jumps of sodium ions that are flowing through those channels there. Basically, if you block those sodium channels, you block transmission through those nerves. So this is where things like lidocaine, how they work. It blocks neuronal sodium channels. It blocks the action potential from ever getting up to the CNS. You never have that sensation of having anything. That's why it's an anesthetic, right? It doesn't stop the actual sensation from occurring there at the site, but it doesn't. Signal never reaches the brain, so you never really know about it. We have a couple of drugs we can use for this, including tetracaine and proparacaine. You can use this for a number of different diagnostic procedures, like if you're doing, say, like a foreign body removal, if you're doing tonometry, if you're trying to use like do like a Woods lamp examination to see if they have any kind of corneal abrasions. These are all really good to use some anesthetics because again, it's going to help keep the patient from flinching. They're not going to feel any pain, anything like that. Big thing to note: never prescribe anesthetic agents for the eye outpatient. Well, why do you think that is? Right, so they might use them too much. They might start to self-treat, and they may have something really bad going on that they need to be evaluated for. That's one thing. Also, this actually eliminates your blink reflex. Right, so the patient may need to blink, but they're not really getting that sensation of their eyes dry. So then, as the eyes dry out, you're more likely to see damage done to the corneas. You can see corneal abrasions, things like that. So that would be another thing you want to watch out for. Right, this is actually a problem. Cocaine is actually one of the first anesthetics we actually ever discovered because it has sodium channel blocking effects very similar to these anesthetics. Patients who smoke cocaine or crack, they actually have problems where they have what they call crack eye because as the vapor kind of comes off of the pipe and it hits them in the eyes, they have some of the anesthetic effect and they actually eventually lose that blink reflex, and they can have eye damage that occurs over time. So again, don't do drugs; they're bad for you. But again, don't write for prescriptions for these. Only use them for, in the actual office or the ER kind of setting. And we have some cycloplegic agents. What do you think these do? Yeah, they're going to dilate the eye and prevent them from clamping back down. This is going to be really good for doing some fundoscopic examinations. If you're doing things like having uveitis and you're relieving ciliary spasm, these are all going to be really good for that. And basically there's a couple different ways we can do this. We can use antimuscarinics, right? So instead of having a drug that activates those muscarinic receptors causing miosis, you're blocking those receptors, and now you're going to cause mydriasis, okay? So this is where we can have things like atropine that does this. Anyone ever heard of atropine before? Yeah, it's usually a heart medication. We can use this if you're coding. If your heart stops, we can give them atropine potentially to hopefully speed it back up. We can also use this intraocularly to help cause mydriasis. You can also have a drug called cyclopentolate and then tropicamide. These all do the same thing by blocking those muscarinic receptors, essentially. Big thing as far as side effects go, if you imagine if your eyes are really mydriatic, how much light are you letting in to hit the retina? A lot, right? So you're going to see photosensitivity. You can see blurred vision associated with this. So again, those are the main side effects. This is why when you get your eyes dilated, the doctor's office usually, you're having to have someone drive you home or something like that. If they're giving you one of the antimuscarinics, they tend to stick around for a while. We also have a different class we can use to do the same thing called sympathomimetics, and this basically means it's mimicking the sympathetic nervous system. So these are going to be things that are activating alpha receptors within the eye to cause basically the same effect, same mydriatic effect. So again, these are going to include phenylephrine, which you may see used in some over-the-counter cough and cold products. Again, doing the same thing here. This is probably the most common one you're going to use. The nice thing with using phenylephrine instead of like an anticholinergic is you still maintain better accommodation to light. So patients typically have less blurred vision, but it won't be nearly as potent as you would see with the anticholinergic. So, and then if you're actually doing say like a corneal exam, what you can do is use a product called fluorescein. So anyone's ever heard like a fluorescein fluorescein stain, and you use like a Woods lamp or a black light to look for any kind of abrasion or anything going on there. This is the same thing that goes into your radiator fluid. So when mechanics are looking for leaks in your radiator, they can shine a black light and they can do basically the same thing. There's fluorescein in there that'll light up. So if you ever wonder why radiator fluid lights up like that, that's why. But we can give it to the eye. It's not really dangerous there. And really the only thing you see here is hypersensitivity, some burning sensation. Most of the time we're going to be giving an anesthetic along with this beforehand. That way it kind of numbs up the eye. You can apply basically it's a little strip. You should apply it basically down into the conjunctiva, and then it'll kind of diffuse over the eye. And then just one you might use if you're ever dealing with ophthalmic surgery. This is called Trypan Blue or Vision Blue. This is actually nice because it will sequester itself into the lens, and you can use this for a vitrectomy to help guide excision. You kind of have a better idea of exactly where the lens is at. Staying may last for a while to a week, but it's something you may use if you're ever dealing with ophthalmic surgery. So that is ophthalmology. We were able to get through pretty quick, mainly because we had already covered the antibacterial stuff, which is good. So we have a little bit extra time. We'll do a little bit of review. What type of questions do you have right off the bat? Anything from the quiz you think, hey, maybe this is something I don't actually understand, or I'd have a question about?
How do you recommend, I think everybody tries to do some sort of chart.
Yep.
But charts can only help you so much because you have to pick a way to organize it.
Yep.
So what would you recommend for how we can mentally organize the information so that we're retaining it?
Mm-hmm.
That's my biggest problem.
A lot of practice. So practice is going to be, it's like, how do you get to Carnegie Hall? You practice. Same thing here. How do you pass a pharm test? You got to practice a lot, right? So that's one of the big things. A lot of people will kind of put that off to some degree. Don't do that, right? Do it a little bit every single day. I would say be able to look at a drug. So you saw that like on the quiz here, most of my answer choices come down to four or five drugs, right? So it'll be which of these drugs are going to be best for this patient. And so your goal when you're looking at the answers is to look at each individual drug, say, okay, I know this one's a macrolide, I know this one's a penicillin, this one's an aminoglycoside, and based on that, you can link it back to kind of this cloud of knowledge you have about each of those individual drug classes. So you say, hey, okay, aminoglycosides, those are really good gram-negative killers. They have pseudomonal coverage. I have to watch their levels because if they accumulate, I can see nephrotoxicity and ototoxicity. Like those are the things you should associate with the drug classes, and then being able to pick out those individual drugs from that class, right? So being able to pick out a macrolide versus a penicillin versus cephalosporin, things like that. Obviously, cephalosporins you have to be able to put them in their generations to kind of know there's a little bit of differences there. Those are probably the roughest ones, I would say, just because the names are so similar. But yeah, those are probably the things I see most students have the hardest time with. Yes, ma'am. Yeah. There's not a really good way to, you just have to kind of pick out a few. That's why I try not to, the list of each, there's only 2 or 3, in each kind of category to kind of note. So like the 4th generation, like really the big one's cefepime, right? And note the difference in cefepime coverages versus your 3rd generation, like, ceftonir. 3rd generation is kind of tough because there's like cefotaxime, there's cefixime, there's Ceftiraxone, yeah. But being able to just kind of pick them out and say, okay, this looks like a 1st generation, this is a 2nd, 3rd. I don't ask a ton of questions about 2nd generations because I don't use them all that too often clinically. But 1st, 3rd, 4th definitely are going to come up pretty frequently because those get used all the time, in the outpatient world or even in the inpatient side. Yeah, so be aware of like unique side effects that go along with some of these drug classes. Things like GI upset. Like, okay, well, every drug causes GI upset. There's no point in realizing that. But there's special things like clindamycin is going to be more likely to cause C. diff. Like, that's a unique thing to really note. Like, that's something you know about. Anything else? Those are very representative of how I write my test questions. So think along those lines, right? What I found really helped me with pharmacy school when I was studying for this stuff, because again, we had, think about your education, like, you're focusing on a lot of different things. Pharmacy is just a small piece of that. Imagine just expanding that out, and that's kind of being like all of pharmacy school for like 4 years. So we had to go really in depth on a lot of this stuff. The best thing I found to help me study and to memorize a lot of these facts and things is just to come up with questions. So if you have a study group, come up with fake test questions or quiz questions to ask each other. That will help you to make sure that, one, you understand what you're talking about, because someone can be like, well, that's not right, and you go, well, is it? And you go back and look it up, and you learn something, right? Or if you can explain something to someone else, you know that information a lot better than if you can't explain it, right? So make up fake questions, ask each other, kind of bounce stuff off of one another. I find that's a very useful way to, especially if you already have an idea of what some of these questions look like, those are good ways to test yourself, right?
Okay.
Yes?
For example, when you're talking about eyes, you have a lot of drugs listed maybe on one, like antihistamine. So do we have to know all of them?
Yeah, so if you were to see one of those, know that, hey, that's an antihistamine versus that's a mast cell stabilizer versus, yeah. The only thing I would note is on the antivirals, like in the antifungal eye stuff, like I highlighted just a few of those because most of the other ones are systemic or systemic there.
You mentioned a website for practice questions.
Yeah, so if you go to Access Medicine, right, there is a review section there where you can, based on the textbook, and I'm not sure what textbooks you guys have access to versus, because I'm used to, the Nova library versus your guys' library. There's a little bit of differences there because you both have Access Medicine, but the rights are a little bit different. But look for pharm questions, like look in different books, like, there's probably, was that current diagnosis? Like look in that book for questions that go over ophthalmic stuff. Look up glaucoma stuff. Look up basic antibiotic stuff. You can look at different. What's that?
Here's our Access Medicine. You can look at it.
I can try to look at it. Yeah, things like the clinical diagnosis and treatment are probably pretty good. The neurology app is probably good as well. Yeah, if you see anything like the current series of books, those are generally pretty good. Pull questions from it. Again, they're not going to be the same as what I would write, but they are at least getting your mind kind of thinking towards that test-taking kind of mentality. Yes?
I've heard different things, so I just want to confirm the test is at 3:15 on Wednesday?
It'll be the hour before class, so that way we can just kind of hit the ground running with the next section. I'm not even sure what we're doing next section, but it'll probably be something we need to hit the ground running with. Yeah, so it'll be the hour before. You'll take it then, and then we can come in. I won't be able to give you any feedback on the test at that point because I'll have to go validate it afterwards, and then figure out if there's any givebacks or any changes or anything. Yes.
How many references do you want for this assignment due next week?
As many as you need to adequately answer your question. My lectures do not count as a reference. Someone tried to slide that in last semester. I let it go, but I was like, I don't know if I could. Well, not really the spirit of things. Any other questions? Please reach out early. The sooner you can email me or anything like that, or if you want to meet before class. Well, I guess I won't be here that early next week. But if you have questions, please email me. We can always set up a phone call or Skype or whatever you want. I try to be as available to you guys as I can since I'm not here, full time. So, all right. I'll see you guys next time. Hopefully everyone will be